Morning, Jeff.
kill the background.
So good.
Morning, Anna and Jeff.
Morning, Pooja. How are you?
Good, thank you. How are you guys?
Very good. And you, Jeff?
Yep.
Yep.
I'm just not quite sure how to cancel the sharing.
I think it's stopped.
Yeah, I turned the music off, but
That's all right. It'll stop. I'll take over if I don't think I'm sharing my screen for anything today. It'll work out.
yeah.
Pooja, you work with emergencies, don't you?
Yeah, I do some emergencies now, yeah.
Yeah. And do you have an emergency department or are you primary?
So where I am currently, we don't do primary. It's actually referral only.
Yeah.
But like last year in Canberra, because I've moved now. So last year in Canberra, it was primary.
Yeah, okay, right. Yeah. Where are you now again?
Geelong.
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 Geelong. That's quite a big move.
Yeah, I just keep moving in hopes of doing something more.
Oh, yeah, I'm the opposite. I'm hoping to do less.
Victoria's like that. As you move towards the border, it's How Long is the name of the town.
How long?
Oh,
Yeah.
okay. Didn't know that.
Oh dear.
I have visa issues because currently I'm on a regional visa, which means I can't be in Sydney, Melbourne, or Brisbane.
Oh.
And I want to pursue specialization, so I'm
Yeah.
really stuck.
So how is that forever?
No, thankfully not. Otherwise, I think I would just
Yeah.
quit.
Yeah.
It's not forever. It's a 3-year thing. So, but then I have to apply for PR again. So I'd applied for PR, but what I got instead was this regional visa. So for 3 years, I couldn't apply again, but next year I'll be able to apply again. So we'll see what happens.
Yeah.
It's very, I mean, sorry, this is recorded and it's not really relevant to what we're doing right now, but it's very frustrating.
I can imagine. Yeah, absolutely.
Because I've trained here, like I trained in Melbourne, so.
Yeah. And is the visa thing because you went back to India or
I didn't.
you
No,
didn't? So you
no.
went straight through.
Yeah,
Oh,
I've been here 10 years now. Like
yeah.
it's over 10 years.
Oh, very
And
nice.
I'm still struggling with visa.
Yeah. Well, the reason I asked who's doing emergency work, and I know where Jeff's working, so I'm not gonna I know he's not doing primary accession emergency work, but I feel like with emergency everything changes. Like we have these like big shifts in, oh no, you can't do that anymore, and oh no, we absolutely must do that. And I don't feel like we get that quite so much in medicine and then GP and like everything's a little bit more kind of, yeah, but we did that 20 years ago and like maybe it'll swing back around again, you know?
Yeah.
So I am a little bit self-conscious teaching medicine, teaching emergency medicine because I feel like there's a good chance I'm out of date, but I can only really speak to my experience and I'm not doing emergency work at the moment at all. So I'm not really amongst the chatter of like what's the done thing right now. Having said that, this Edinger is pretty up to date and it does talk about the controversies about the different kind of approaches to emergency medicine. So hopefully we can have some discussions around those. Morning, Elle. You don't have to. Hello. Welcome.
Thank you. Sorry, I'm just eating breakfast and getting ready for work.
You're so fine. You don't have to have her on. Thanks for coming.
Thank you.
Are you doing emergency work at the moment?
Yeah, so I work in GP and I do casual emergency.
Ah, lovely. Are you Sydney based?
Yes, I am.
Ah, okay. Do I know you?
I know your name. I work with Martine Perkins in
right.
Lara.
Yeah.
So
yes, right. No, I know Martine well.
Yes.
Okay, so kind of just the reason I'm asking is just kind of where we pitch this discussion as far as like who's seeing what cases and what's going to be the most relevant for people. And I think the most of the people who tune in after the fact are in general practice rather than specialist hospitals or primary emergency hospitals.
Yeah.
But we will kind of go through some of the kind of controversies and stuff and basic principles. But the first chapter we're covering is just emergency medicine, triage and initial stabilization. And I think everyone's got pretty good instincts on that. Once you've been a vet for 2 or 3 years, you start to just kind of develop like very kind of gut instinct sort of, this dog's so annoying today. What's wrong with you? What is it? Sorry. Yeah.
Needs to go outside or be fed.
It's actually, I got her food out of the fridge and then didn't put it in her bowl, so that was a mistake. That is exactly the problem. Well done, Jeff. Yesterday she was like this, and I was like, "What is it?" So her name's Skippy, so we always say, "What is it, Skip?" Like the kangaroo, and she had a tick on the inside of her back leg, and I said, "What is it, Skip?" And she rolled over and was like, "Yeah, it's this." Like, oh, okay, thanks. So now I'm like paranoid that she's got something else to tell me, but actually it's just that I haven't put the food in her bowl. So distractions aside, the first chapter we're talking about is triage, and as I was saying, most people just have a really instinctive way of triaging. But one of the things that's kind of coming about now is that people who use a triage list, like a list of like, I need to assess this, and this, tend to triage more accurately than people who don't use a list. So is anybody using a triage list?
Sort of. I mean, in my head, kind
Yeah,
of, but
yeah.
it's not really essentially you're just checking like airway, breathing. Is that what you mean?
Yeah, exactly. Yeah.
Yeah.
So with like human medicine, kind of first aid, CPR, they've got the ABC, Dr. ABC, that you can follow. Whereas in most of the time, we're not seeing emergencies in community, we're seeing them in a hospital setting. So we don't have to do the kind of, is there any danger to us part? But essentially, the goal of triaging is to work out how long a patient can wait before it needs intervention, basically, or stabilization. So most practices will use a coding system where they apply a color or like code red or code orange to a patient according to how urgently it needs input. Is anybody using anything like that?
Yeah, last year we used to, because we were seeing primary emergency, we used to do that. So triage, like how urgently you want to be seen versus can you wait in the waiting area for like an hour, 2 hours till somebody gets to you?
And I think that's the reason why it's so nice is if you kind of really like just, okay, you are a red patient, you are an orange patient, you are a green patient, you are yellow. You can kind of visually sort of say to the clients, we're dealing with something that's a lot more urgent than you. So if you're in an emergency clinic or a GP that sees a lot of urgent care stuff, and you say, have a poster in your reception area that says, like, these are the codes that we use, and you tell people on your triage, okay, this is a green. What that means is that we're going to deal with any patients that come in with like red, orange, yellow ahead of you. And people then sort of go, oh yeah, you're dealing with much more serious things. And if you have on your chart in the reception area or triage area, code orange means life-threatening hemorrhage, code red means cardiac or pulmonary arrest or respiratory arrest, then people go, oh, right, okay, that's what serious is, because they think that their patient is obviously the most serious. So it can really help with managing client expectations and helping them to understand why you're taking so long potentially to get to them if they're there for an ear infection. So that's kind of the triage like poster that you put up in reception, but actually the triage list, what should be kind of top of your list to assess when a patient is kind of presented to you in whatever state that comes rushing in the door in?
Whether it's breathing or not, like that's the first thing. And
Heart rate.
perfusion.
Yeah, is it alive? Like number one, so cardiorespiratory function. So they recommend that the first thing you look at is airway and then breathing, so AB. And I'm not sure whether that's just convenient because it's ABC. I'm not sure that that's more important than cardiovascular. You want to move to cardiovascular pretty quickly. But first thing they recommend is assessing the airway. So when we're looking at airway function, what are we looking at?
Patency.
Yeah, good. When we do our assessment, like if you put yourself in that situation, where are you putting your hands? What are you looking at?
I think we all probably subconsciously start even as we're like walking towards a dog, like because you'll hear like a lower part, or if you heard like a French bulldog breathing versus if you heard like a border collie breathing in the same way, you'd probably be a little bit more panicked.
Yeah, so true.
You're probably just like, I always feel like I just start listening to them if you've got a patient that you're worried about respiratory distress.
Yeah, for sure. And watching their respiratory pattern, isn't it? Like as you're approaching the patient, you're watching for, might there be an airway obstruction as opposed to pleural effusion or some other like pulmonary parenchymal cause of respiratory distress.
Yeah.
Color of the tongue as well as you're approaching them.
Excellent. Yeah, so if they're sitting up looking at you panting, that might be a normal stress response. But the color of the tongue is going to tell you a lot about cardiovascular function as well as about respiratory function. So obviously cyanosis. What equipment might you reach for immediately or might your nurses have already reached for immediately?
Tube, ET tube.
Yeah, for sure. If they're cyanotic and not breathing, not conscious. What else? If they're awake.
Like you should check the SpO2 and get the oxygen mask.
Yeah, exactly. So there's no downside to putting them on oxygen if they've come in collapse for any reason, really. So popping them on some oxygen and just putting the SpO2 monitor on them. I would never delay giving oxygen to a patient, but I love to know what their SpO2 is before you put the oxygen on, just to give me a better understanding of what barriers there might be to gas exchange and stuff like that.
Does that help like any prognostically as well, or not really? Not really.
No, more diagnostically, actually. Like, are they oxygen responsive? Or are they like, if you see them sitting at 90, were they at 90 when they walked in, or are they actually, or is the SpO2 monitor even working because the animals be like this and panting? Yeah.
The other thing, I guess, with those respiratory, like dyspneic kind of patients, like probably like, would you want to have like Torb handy or something potentially to calm them down?
Good, exactly. Yeah. So the other piece of equipment that we're kind of reaching for, if there's respiratory distress, like we haven't even started assessing cardiovascular function yet, but IV catheter. And often this is where like having triage teams is nice. You've got people who are putting the oxygen mask on, putting the SpO2 monitor on, putting the IV catheter in while you're able to do your kind of initial assessment, watching examination, auscultation and stuff like that. So we kind of covered airway and breathing together, and all of the things that we're kind of reaching for are going to be similar for both of those. And it's pretty rare in my experience to be able to say this is an airway problem versus this is a respiratory pulmonary parenchymal problem based on that very initial triage. That wouldn't be my expectations, but we could say, are they oxygenating adequately? Can we get them to oxygenate adequately with oxygen supplementation? And are they ventilating, essentially?
When you're determining the oxygenation, if it's poor, is it upper airway or is it lower airway?
Yeah, so I don't think you can tell that necessarily from oxygenation levels.
No, but by character of breathing, you can.
Oh,
and
yes, yeah, often.
And my favourite diagnostic technique for chest and percussion, because I can pick a pneumothorax from a hydro of any description thorax.
Yeah.
Just with 2 fingers or 3, or 3 fingers, or 3.
We're going to need a demo of this, Jeff. We need one of those stethoscopes that broadcast the sound that you're hearing, so you can show us.
Yeah. And if it's hollow and tympanic, well, you go for tapping materials, and it's dull, the ultrasound to find the fluid and tap it in the most auspicious position.
And what other, so we're sort of like pulse ox, catheters, oxygen mask. There's another piece of equipment that if you've got a patient that's presented in respiratory distress, that we've started to reach for more commonly to assess respiratory disease. Does anyone think what that might be?
Oh, I'll get the ultrasound because I want to do a focus and see.
Yeah, absolutely. And that can really, like Jeff, where Jeff's got so much experience with percussion, I can't assess a chest with percussion. I'm spoiled and I use an ultrasound machine. So pleural, you can rule out pleural effusion, pneumothorax, extensive pulmonary edema, bronchopneumonia as well. So all of those things will have quite characteristic changes on an ultrasound and help you guide your next steps therapy-wise and guide the client as well.
Is cardiac tamponade easy to see on ultrasound versus X-ray?
Yeah, much easier on ultrasound in my experience. Yeah, because the nice thing about it is the pericardium fills up the fluid, which means it like comes in contact with the chest wall and pushes the lungs out of the way. So you actually get a much bigger window than you would get in a non-pericardial effusion dog to see the heart. I think tamponade is quite hard to diagnose, like as in like actually seeing right atrial collapse is quite a niche sort of like it's quite a specific view and window to get, but you can see pericardial effusion and then if they're collapsed, you can assume that there's cardiovascular compromise and therefore tamponade.
The other thing perhaps of interest is there a space occupying lesion in the abdomen that's compressing the chest.
Yeah, sure. Yeah. And that's something we've probably like on approach, just appearance of the dog, like a bloated abdomen or something like that would be, maybe we need to look in the abdomen for this problem.
You've already assessed the signalment, and I can give as an example a bulldog I saw once that came in quite severe distress, and it came with an ECG, which was handy when it arrived.
Yeah.
And it kept collapsing, and the ECG had very low complexes, and being a bulldog, I thought, that'll be a heart-based tumor, and it's probably got cardiac like tamponade, and the ultrasound out, and sure enough.
Yeah. Can you explain why chemodectomas or heart-based tumors are more common in brachycephalic dogs? Or what made you think of that?
I just somewhere out in the back neurons there.
In the files?
While they were still,
Archives.
I remembered that it was more common in that breed.
Yeah, I've never.
Is it because of chronic hypoxia? I think I read that somewhere.
Yeah, they think so. Yeah. Chronic hypoxia leads to hypertrophy of the chemoreceptors and then chemodectoma development. And then what is the mechanism of bradycardia in chemodectoma? Because the pericardial effusion, they should be quite tachycardic, right? They're not getting decreased venous return, decreased cardiac output. They should be tachycardic. Why are they bradycardic?
Yes, it's a parasympathetic overload for some reason, but I don't know why.
Where's the tumor?
Heart base.
Right, it affects the nodes.
Yes. Yeah. So it affects. So it's sitting next to which big structure where all of the baroreceptors and chemoreceptors are?
Aortic arch.
Aortic arch, exactly. So if you put pressure on the aortic arch and you increase afterload in the heart, how is the heart going to respond to that?
Expand.
Rate wise.
It's going to slow down because it's going to see that as like systemic hypertension.
Exactly. So the mechanism of like carotid massage, you're increasing pressure on the arterial system, which increases vagal tone, which drives heart rate down. Cool case, Jeff.
Yeah.
We didn't test that on triage though.
Anna, what after you said the hypoxia chemoreceptors, and then you mentioned some chemo, something else. What was the next word in that?
Baroreceptors, maybe?
Or chemodectoma?
Yeah, that. What was it?
Chemodectoma. So heart-based tumors are typically chemodectomas. They typically arise from the chemoreceptor cells in the aortic arch.
Oh, okay.
Yeah. So if you've got a tumor so heart-based tumors typically describe aortic root tumors.
Yeah.
Right.
It does become
Or
a little
AVT, aortic base tumor, sometimes they call it. That's the
Okay, so these are not they're not hemangiosarcoma tumors.
This is where it gets a bit tricky because on ultrasound, sometimes a right auricular tumor will look like it's in exactly the same location as a heart-based tumor, and sometimes we can misdescribe them. The
Okay.
difference imaging wise is that a heart-based tumor, like a true chemodectoma, are very homogeneous, very round, quite distinctive, like just you see the aortic root and then you see the chemodectoma kind of next to it. Whereas hemangiocytes tend to be a little bit messier to look at. They're not as well circumscribed, they're more cystic, they're less homogeneous in appearance.
Okay. So the brachios are not, it's not cardiac hemangiosarcomas. Okay, fine.
Exactly. More commonly, they still get hemangiosarcoma as well, but if like breed wise, if we're pattern recognizing, I think hemodectoma is much more common.
The other clue with that bulldog was the fact that the ECG on paper arrived with the dog and there were low voltage complex.
Yeah, we're so spoiled in referral medicine, Jeff. These emergency vets are like, damn it, that never happens. Good, excellent. So we kind of moved on to circulation or cardiovascular assessment. What other pieces of equipment that we not talked about yet that we might add to our assessment if we start to think, oh, is this a cardiac case?
Blood pressure or
Blood
ECG?
pressure, love it. Yeah, and in fact, if it's a collapsed case, like if it's an emergency case, we should probably be reaching for something to assess circulation, regardless of whether it's kind of cardiovascular etiology or not.
Stethoscope. I don't know if we mentioned that already.
Yeah, perfect. Yeah,
Like auscultating. If you're not going to kill the patient by auscultating them, then
yes. Good point, actually, which we didn't really talk about with respiratory. Sometimes you've got to get the sedation in, and sometimes that has to be IM because you don't have another option and an oxygen cage and a stand back and wait, because if they're too distressed, we'll kill them.
To be honest, I usually always do IM first. I don't, unless they collapse, but if they've just come in like sort of dyspneic, I do IM, shove them in oxygen for a little bit and then take them out again.
I wish the line between respiratory distress and collapse was more clear.
Yeah.
So sometimes I find I really just want to get an IV in and anesthetize and intubate because we're right on the cusp here, but I don't want to cause that.
Yeah.
Especially cats, they can just die on you.
The other thing was, depending on the historic circumstances, heat stress.
Yeah, exactly. Yeah.
Yeah.
So who does triage with the client? Are you guys
I used to.
Sorry?
I used to.
Yeah.
Well, when I was in country practice, the client would be the nurse. Like they would help me put the catheter in. They'd help turn the dial and anesthetic when I was in surgery. To help do everything.
I actually, well, it seems crazy, but actually that's my preference. It's quite uncomfortable to do a lot of this stuff, like particularly when you're kind of like, I'm probably going to cause this patient to get worse in the process of getting it better. But I feel like you get so much historical information as you can ask questions as you're kind of doing your examination. Say, is there any way that this has had access to snail bait or something like that as you're doing it? And then the other thing is just consent. Like they see how much goes into stabilizing the patient. They see that you don't have time to say, this IV catheter is going to cost $70. Let's sign for that. You know, like you can say to them, I'm going to rack up $450 just working out what's going on, and then I'm going to be able to quote you more accurately as you're going, and they can see the value in that because you've just used 10 pieces of equipment and 3 staff members to work out what's going on in their patient. So it is kind of my preference, and I do think that there's a room for that as long as you don't, when owners are very distracting and you can't actually maintain a train of thought. That's the only reason I'd sort of say, okay, you need to go outside. Anyway.
You just tell them, I need you to like not talk to me right now.
Yeah. I think, and most people would be quite responsive to that. Like, I'm really worried. I really need to be able to listen to your dog's heart. And then I just put my ears in. Yeah.
I've done that sometimes in CPR situations. Like I've got the owner in to see while I'm doing. So especially if they don't let, like after 2 or 3 rounds, if it's not, if you can't bring back the animal, then I will actually get the nurses to get the owner so they can see. And then like sometimes I feel if they visualize, then they make that decision a bit more readily. That
I agree. It's quite traumatic to see, and most people will say, oh, stop doing that to my dog. The cat. Yeah. I agree. If that's what the decision that you feel like is the right decision, that's a good strategy. All right. What about pulses?
Yeah, like I would probably go for a femoral pulse, potentially like in concert with trying to get an auscultation of the heart, just to know that the blood's moving.
Yeah, agree. So femoral pulse for sure. They've got to be pretty collapsed circulation wise to lose a femoral pulse. Then I guess fake cats, obviously that's going to be like helpful in your diagnosis. But what other pulses can help you get a better feel for perfusion?
Also pedal as well.
Dorsal pedal, exactly. So that when you get to kind of, I think 5% dehydration, I wrote this down somewhere. You lose dorsal pedal pulses typically, and that can be just a marker of perfusion and kind of urgency of volume resuscitation. What about temperature? How can that help us assess circulation or perfusion?
For cardiac cases, definitely it'll lean you more towards cardiac if, I mean, it's not just one thing, but that'll add to your suspicion if you have hypothermia as well.
Hypothermia, yeah. So what is it with cardiac patients that causes hypothermia?
It's one of your it's poor perfusion, so one of your perfusion parameters, so cardiac, but actually any case of shock.
That's exactly what I'm getting at. Yeah. So if you've got, you might have cardiovascular causes of shock, so decreased cardiac output, and then therefore decreased perfusion to periphery. But anything else that causes a shift in cardiac output or fluid distribution will potentially cause hypothermia as well. The reason why it's so important is that cardiovascular, you don't want to fluid resuscitate them, whereas any other cause essentially you usually do want to fluid resuscitate them. So I saw an interesting thing in Edinger actually, that someone's done a study to look at the differential temperature between a rectal temp and a interdigital in a hind limb between the 3rd and 4th digit. And if the difference is greater than 6.5 degrees Celsius, then what was the conclusion? They're definitely in shock. So if they're because you're like instinctively you touch their paws and go, oh, they're cold. Whereas this is like a really nice kind of cutoff. 6.5 degrees difference between a rectal temp and interdigital. And you can say probably need some fluid if they're not cardiac.
Sorry, what was that temperature difference again?
6.5 degrees.
Celsius?
Yes, Celsius. Yeah.
6.5, not just that.
Yeah, because obviously the cutaneous temperatures are much colder. Like if you did that in a healthy animal, you're going to get quite a lot a lower temp between the toes.
Yeah.
Than a rectal temp.
I mean, a lot of that assessment can be done without any equipment, just using eyes, fingers, and brain.
Yeah, for sure. And I guess where it's nice to have like objective measures is when you're a new grad, I think, or when you don't have that clinical experience to say, this feels too cold to me. I'm gonna I'm really worried about perfusion, and I just before I sign up with the fluid bolus, I want to do an LAAO or something like that.
Yeah. Sorry to interrupt. Just rewinding back to determining if it's like cardiac based shock versus other type cardiogenic shock versus others, and making that decision about when you would go to like fluid resuscitation quickly, like without doing an echo. What's your decision tree? So you said if they're hypothermic, it increases your suspicion that it's cardiogenic shock.
No, it's shock. So if they're hypothermic, I think it's shock, and it doesn't help you differentiate between cardiogenic or not.
Right.
So presence of a murmur,
right,
history of heart disease,
yeah,
B lines on a POCUS,
yeah,
and an increased LAAO would probably be my kind of 5 minutes from, okay, I'm not going to give this dog a bolus. And obviously history, like slowing down on exercise, coughing, fluid coming out of the nose. Like if a patient looks hypervolemic, but their perfusion's crap, it's probably going to be cardiogenic rather than
they're a couple of years.
Very, yeah.
Okay.
The nasal drip. I love a nasal drip actually. I think that's an underrated assessment.
That's the other drug that I'd have ready to handy, with the alongside the TORB would be having some furosemide pretty.
Furosemide, yeah, absolutely, yeah. Bag of fluids, furosemide, adrenaline, yeah.
Everything. Put them
I
all
know.
in a pack.
Do you know what though? I think the more you've got kind of set up, the more confusing it gets. Like, because there's so many drugs that you could reach for in an emergency, like atropine and all of the rest of it. I worked in a clinic when I first graduated. In fact, I nursed there even before I graduated. And they used to have adrenaline drawn up, made up in 1 in 10,000 dilutions next to the flush syringes. But what people often did is draw up, yeah, you know exactly where this is going. So what they often did is draw up the adrenaline into a 10 ml flush syringe that was already made up and labeled hepsaline. So like you put the syringe down the wrong way up, you put an adrenaline label on the other side of it, but you put the syringe down the wrong way up and it just says flush. And I'm flushing this cat's catheter with like 1 in 10,000 adrenaline and its heart rate's going, oh, and my assessment's going crazy. Like, what is wrong with this cat? It was fine, but it was quite a wake-up call to having appropriate systems in place to avoid things like that. And
Yeah.
how long does it take to snap open a vial of adrenaline and draw it up into a syringe, you know? Like, shouldn't have been.
Other interesting thing there is adrenaline, once it's drawn up and diluted like that, is supposed to have a shelf life of almost 0.
Is it?
Yes.
I thought there was
Stability-wise?
something about the plastic as well. Something about
Yeah, right.
having
Well,
a peak in
I can
plastic.
vouch for that it definitely worked in this case. It definitely, yeah, it wasn't a problem for the
Well,
efficacy.
I can vouch that you don't need much because a dentist got adrenaline in my doing a block and I went straight into the vein and I was like, and I'm
Whoa.
bigger than a cat, so
Oh,
you
Jesus.
don't need much.
It's a terrible feeling, actually, isn't it?
Yeah, it was crazy.
It's bad. Yeah.
As if the dentist wasn't bad enough.
Yeah, exactly. Yeah, never again. That's it. Okay, so in our checklist, we've done airway, breathing, circulation. So in circulation, we've done like cardiac and vascular perfusion. What else do we want to assess?
Mentation.
Love it. So neurologic function. So what indications might we have that there's compromised neurologic function?
Auditory mentation, like that's the first thing. You look at the eyes and just see what the
Yeah.
like pupils are doing.
Like consciousness, I suppose, which I would almost argue you assess almost before you assess anything else on this list.
I
Yeah.
agree. It's very blurry lines, but it is
Yeah.
a nice thing to go, did I actually look at that in hindsight almost? Like if you're kind of then applying a triage score or color to a patient, like did I go through everything on this list? So mentation, consciousness, I would say same thing, probably. Because the mentation goes down to comatose. Yeah. So what about seizure activity?
Yeah, like if it's toxicosis, you're looking for like evidence of diarrhea, like color stain,
Yeah.
salivation, all of the is it sluted?
Is it what?
Salivation, lacrimation,
Oh,
urination,
oh, yes, yeah.
What's tremor?
Urination, defecation,
Yeah.
Yeah, back in my early days when things were more simplistic, I was working in the country and Lucy Jet was the favourite thing to poison crows and dogs in
Crows.
carcasses.
Yeah.
Used to maintain organophosphate poisoning.
Yeah.
The cranial half of the dog would be wet with saliva, the caudal half wet with diarrhea.
Oh, wow.
Relation.
Yeah, I saw heaps of these kind of toxicoses when I was in practice.
Yeah, I can imagine.
My first year, there was in the first year that I practiced in the country was a mouse plague. And so it was like rodenticides for 6 months and then eastern brown snakes. And then the second half of the year, they ran out of rodenticides. So they were releasing snail bait from planes. And then
Oh my God.
Yeah.
We are so spoiled.
Like every weekend I'd have like 10 rodenticides getting bloods. Like,
oh my God. Just have a like army of greyhounds out the back, just confusion.
Well, back then it was, probably shouldn't say it because this is being recorded.
Yeah, don't say that.
Yeah.
Lot depends on geographical situation, as you can see. Like, for instance, is at autumn, because in autumn the mice come in from the field, from the paddocks, and
Yeah.
people poison them. So it's more like in urban practice, more likely to be a rodenticide. Whereas in spring, it's more likely to be molluscicide. Well, in Canberra, it certainly was, because everybody was out poisoning their snails.
Oh yeah, of course.
Mm.
Yeah.
And yeah, and you know, if you're in snake country, well, what variety of snakes live in your area?
It's the last week of in Griffith where I worked. It was the last week of August. We'd just get like, the first dog would like run through the door normally like 5 p.m. because that's when people like get home and find their dog like envenomated. And then it was literally one day in end of August, you'd then get like a run of them in the first week when the snakes kind of woke up, and it happened like
full of venom.
And crazily, it was also the same week always that parvo started.
Oh, how annoying.
Yeah.
Take a holiday that week. Jeepers.
Yeah.
When the flies came out.
Yeah. And talking about respiratory assessment, for us it's tick paralysis. Like this time
Yeah.
Yeah. I did a workshop in Tamworth a couple of weeks ago, and the cases that they have walking through the door are amazing. Like so interesting. We had like it's essentially find the grass seed at this time of year, but like there was a dog with a Horner's syndrome, higher thorax, and something else going on.
In the same dog.
Same dog. It was so cool.
So much crazy
I'm really struggling to concentrate on this ultrasound course that I'm supposed to be teaching, but let's use this dog as a model.
The best one that I got in the country was I got a dog that was hit by a car. So I'm also keen to hear where pain comes into this. And I think we parallel process things like mentation as they walk in. And a lot of this is just parallel processing in your brain. But I had a diaphragmatic hernia / cesarean for an at-term border collie, and so we did a cesarean with 8 live puppies and a diaphragmatic hernia repair, all in the same emergency surgery from a hit by car.
That's quite the emergency surgery. How'd the puppies go?
It went amazingly well.
Yeah.
And they're unwell are more likely to get hit by cars and things like that because they're not as attentive to their safety.
Yeah, so true. Tick paralysis is classic. They come in hit by car often. Not often, but
I never thought about that. But
yeah, they can't run away. Yeah.
Local knowledge plays a big part in parks. When distemper was rife, it came in from the western side of the town and gradually migrated through the town, went out the eastern side. But and you knew that if they were fitting, that distemper was probably likely if it hadn't been vaccinated.
There's an interesting outbreak in Europe somewhere, I think it's Switzerland, where our dogs are having like periods of really manic behavior, sometimes progressing to seizure activity, like really heightened mentation periodically, and it kind of seems episodic, but it seems contagious or like something environmental where both animals in a household are affected. But they're trying to work out what's causing it at the moment. It might be a new virus. But when you mentioned distemper, there's going to be something weird going on. It might be a food contamination thing. I think that's what they're investigating at the moment. That local knowledge, I think, is so important because detecting outbreaks, trends, things like that, I think vets should be so much more collaborative in what they're seeing, because if, what much more quickly would we detect food toxicoses and infectious diseases outbreaks if people in local areas were saying, we've had 10 cases of diarrhea come in today, what are you seeing? Anyway, interesting. That I like your point about the hernia. I forgot to mention in your breathing, like your POCUS, that's the other thing the POCUS can help you with. So you're going to see guts in the thorax if there's a diaphragmatic hernia. And
what about positionally, like alleviating pressure off the thorax by kind of elevating the top half of the body? Or is that not? Yeah, not great for a diaphragmatic hernia. Yeah, for sure. So if you've identified that you've got abdominal organs in the thorax, you want to give as much kind of like elevate the thorax as much as possible. And in cats, I literally like
Check,
Yeah.
like hold them upright and check them. To try and displace the guts back into the abdomen if you can. If they're in
Because it can
crisis.
require quite a bit of momentum for it to. It's not just a case of if you turn it up and it doesn't slide down nicely, it might need a bit of pressure, not pressure, but
Yeah. I'm not like probably not as rough as I indicated there. the slant, it depends how big the hole is, doesn't it? So if the guts have kind of split up and then got entrapped in there, then you want to shake them out. Whereas like if if there's a huge hole and they're just kind of sliding up, then a little bit of verticalness. Speaking of neurological, what other indications might there be for verticalness? Having the patient on an incline.
Intracranial pressure.
Great. Yeah. So if you're suspicious of increased intracranial pressure, then having them on a slight slope, there's not really a contraindication for that. If you're suspicious like of mentation changes.
And is it do people see, is it the cushingoid sign with like blood pressure up and heart rate down? Is that what it was?
Cushing's reflex, yeah. Cushing's reflex.
Exactly. Yeah.
Hypertension.
Yeah, so that's an indication of increased intracranial pressure, but it's got to be so high before you see the Cushing's reflex. So if you're seeing like high blood pressure and low heart rate in a patient that's got normal anxious mentation, it's not going to be Cushing's. It's not going to be increased intracranial pressure. They're normally like stuporous comatose kind of thing.
Yeah.
Fully sick dogs. And it's really like they get that when they're herniating their brain. Like it's quite, if you sort of seeing it, we actually I used to do MRIs before we had vet MRIs specifically. We used to sneak them into a hospital in Sydney, and it was right across the road from my uni. So I used to just sneak across after uni and help the anaesthetist do it, which was such a good experience while I was studying. But we actually saw a dog's brain like herniating as we were doing it, and you could see the like blood pressure and the heart rate. Like it was like so distinctive. So we were able to sort of hyperventilate and give some Dex and yeah, exactly. While we were looking at MRI.
Is there a place, I can't remember, I haven't done emergency for a long time, but what about, do people ever do like mannitol therapeutic trials?
Yes, the risk, it sort of depends a little bit on the history of the patient. So what would be a contraindication for mannitol in a patient with increased intracranial pressure?
Dehydration, like if you're really dehydrated.
Yeah, great.
Then it's like,
yeah, and then one
if
more.
the brain's herniating, I think dehydration will kill you later.
Yeah, still bear that if the brain's herniating. What about if we've got an intracranial bleed as the cause of the brain herniation?
Well, it's supposedly contraindicated to use mannitol.
Supposedly, yeah. So in theory, the mannitol will leak out into if there's active bleeding, and it will actually draw fluid into the bleed, so it could actually exacerbate intracranial pressure. I don't think we've got numbers to actually say whether that's true in dogs and cats, but in theory, there's a risk of that. So if there's a history of trauma, then I probably wouldn't do mannitol.
Yeah.
I've seen an anaesthetist use mannitol for a Cushing's reflex. Was being subjected to a CSF tap. It was quite effective. The thing that can be effective is hypertonic saline.
Yes, yeah.
100% sodium chloride.
Yeah. So our next chapter is fluids. So let's talk a little bit more about those then. But essentially for this indication, increased intracranial pressure, there's no evidence of superiority between mannitol and hypertonic saline that I've seen. So either or, whatever you've got on the shelf, whatever you're familiar with using, can calculate the dose quickly, just slam it in. Don't slam it in, give it slowly. Sorry. Yeah. Thank you. But like, don't have an argument with somebody about one being better than the other. Like, just this is life or death. But yeah, typically I'm most comfortable with mannitol, so I tend to reach for that. So say we are now kind of at the point of going, I think this is a neuro presentation of collapse. What testing do I want to do? Heart rate, blood pressure, got that. What other testing might we want to do as part of our kind of triage?
As much of a neuro exam as you can.
Yeah.
Have a look at the back of the eye.
Great. Yeah. Have you ever seen papilla edema? No, me neither.
That's a good point, because you can very rapidly assess Menace and 5-7 reflexes, but I picked up 2 brain tumours just by edema of the optic disc.
Have you?
Wow.
And
That's impressive. Again, I think that's a lost art. I think a lot of people aren't very good at looking at optic discs, myself included.
the blood vessels step off the optic disc onto the retina, sort of.
Interesting. The other thing you might be able to pick up in your ophthalmic exam is retinal hypertension.
Mm.
So
Oh, yeah.
if you've got hypertension, maybe increased risk of intracranial bleeding or stroke.
Yeah, or hemorrhages,
Yeah,
which
exactly.
I have seen before. That's a bit more obvious.
Yes, it's a bit more obvious. So I think it's worth doing an ophthalmic exam, even if you're not confident with pupil edema. I think it's worth doing for sure. What about blood tests? What blood tests do we want, in a quick sticks kind of fashion?
Blood
Rapid,
Electron,
your-
vodka.
Sorry, everyone said that at once. One person said
Glucose, lights.
glucose fast. Thank you. Beautiful. Excellent.
Maybe a lactate PCVTP.
Yes, I love it. And that's going to help us with our cardiovascular as well. Why don't we do an arterial blood gas while we're at it? Sorry, just excellent. And then the next
Maybe
thing,
an ammonia if it's weirdly neuro.
yes,
if
and
you've got it.
age, probably age specific. I'd probably go add that on if it's like a 2-year-old or something, or under 1. Sorry about my blocked nose. I feel like a toddler. So the next thing on the list for like assessment, so we've done airway, breathing, cardiovascular, and now neuro. What do you reckon the next system to assess is?
Just on neuro, it's probably metabolic, but with neuro, would you want to do any hepatic encephalopathy marker at that point?
That's the ammonia.
Ammonia. Yeah.
Oh, ammonia. I thought you were saying pneumonia. Okay.
Oh
Ammonia.
no, that's back in breathing. Yeah.
Yeah. I was like, okay.
Ammonia. Yeah. So the only 2 real markers we have of hepatic encephalopathy, well, ammonia is the main one. But bile acids we kind of use as a substitute in some patients as well. But I don't know if there's any point of care bile acids.
I know.
Not that I know of either. So ammonia is probably the one we'd use in an emergency situation.
Yeah, no, that's what I was
yeah, that's what you're thinking. Yeah.
Why pneumonia and neuro? But I was like, interesting.
Hypoxia, mental.
All right. I might have a bit of hypoxia.
Yeah.
The thing with ammonia is it's so labile. You have to do it correctly because I have had instances where people have run ammonia and it's high, but it's actually not really because it's just like the time or the way it's run, it's not correct. It has to be done really rapidly and all of that. So
Yeah.
the collapse animal, I don't think I'm going to run to it. I think I'll go more by history, but because it's not like it is something that I may do down the track, but not at like the initial necessarily state.
Yeah. Sometimes it's nice when you've got someone putting a catheter in and there's a strong kind of history, a young dog, like with maybe an obstructed bladder because it's got a urolith or something like that. Then I'm going to run that on the first sample that came out of the catheter kind of thing. But yeah, I agree. It's not high on the list unless shunt is high on the list. So what's the last system that we need to assess?
Urinary.
Yes. I actually I don't know, it doesn't default into my triage list, but it should because when urinary presentations are so common and so life-threatening, particularly in cats, obviously.
But by this stage of I guess this is the triage list. Like, what about things like Addisonian crisis, DK? Like, I guess by this stage, are you already kind of hearing a history or looking at, heard that the cat's been trying to wee for 2 days?
What we're trying to achieve here is how urgently we need to assess this patient.
Gotcha. Okay,
So what color do we need to put it in? So we're not trying to get to a diagnosis. We're trying to assess the things that are posing an immediate life-threatening risk to this patient.
Yeah.
So urinary obstruction is the other one that we want to screen for. Was that you, Pooja? I'm so impressed that that's on your list.
I mean, I'm not looking at specifically, but the thing is when you're doing POCUS, because I always like that's I do it. So I'll put like depending on if the animal is dyspneic, I'll put it on the chest. If the animal is not dyspneic, then I will put on the abdomen just to see is there a heme abdomen, is there fluid there. So when I'm just like quickly waving the thing around, I'm also looking at the bladder just to see. Oh, can I see a bladder? Does it look like anything normal?
Has anyone ever seen a patient with a ruptured bladder?
Yes.
Oh, yeah, I think so. Yes.
Mm. They present neuro a lot of the time, or cardiovascular. So when you
I
do
had cardiovascular, like the
triage-
animal just collapsed, and I put the probe on. Then there was free fluid. I tapped it, and it was like, oh, this looks like urine. So obviously,
and it was urine. That's nice. So my presentation, the one that haunts me is a cat that fell like 7 stories and could easily have had a brain injury, a spinal injury. Was like, it was neuro exam. I was comatose. Neuro exam was like wildly abnormal, like no local spinal reflexes and stuff like that either. I was like, this cat is like toast. And said to the owner, this cat is toast. The owner was there in my triage. And then the cat just went, just like started moving its legs. I was like, oh, but its potassium had just shot up so high, so acutely that like all his cellular function, including nerves and stuff like that, has just stopped essentially. And then he started to like compensate a little bit. And we finally worked out what had happened. But like the owner was like, it's like you brought it back to life. I'm like, wow, that's lucky.
What
Anyway,
about a bladder rupture though? From
so
a,
vascular. I don't do that. But
they can like they're repairable if
yeah,
you stabilize
depends
it.
where it is. Yeah.
They kind of just tear down one like line rather than kind of just like evolves everywhere.
That's my
Yeah.
understanding, but often they're repairable.
Yeah.
Yeah.
It's often at the junction of the bladder and urethra, so it's a delicate area,
Yeah.
and there's often some neuro and like the bladder's like, because you've like sometimes got to take out like pieces that's not going to sew together in a nice straight line because it's torn.
Right.
Often they've got decreased bladder capacity and stuff like that, but often they need an indwelling urinary catheter if it tears like down the urethra, just so it
Mhm.
can like not stricture.
Yeah.
But most of the time they are surgical.
Okay.
And I was lucky in general practice to have a very, very good surgeon working with me. And I was like, help.
The good thing about those is if you put a urinary catheter into the bladder, it'll drain much better because there's no omentum to stick into it, to get stuck in it.
Yeah,
Yeah.
sure.
And
And obviously the priority needs to be to decrease the patient's potassium. So you need to get the urine out of the body. The waste products need to come out of the body. So if you've got a uro abdomen, drain every skerrick of it that you can, because that is contributing to reabsorption of potassium and therefore metabolic instability. And then obviously like the last section is like other stuff like envenomations, dystocia. Hey, hemorrhage, kind of about cardiovascular. I put that in cardiovascular, but yes.
Yeah.
Anaphylaxis is another one because anaphylaxis I've seen a few.
Good. And
they come in collapsed.
And in a few different categories, like they might be a bit neuro-y, a bit cardiovascular.
Yeah.
And then fractures and wounds and stuff like that. Obviously, trauma. Okay, I really want to talk about fluid. Tell me about fluid distribution in the body, water distribution in the body. Where does it live? Tell me the
Extracellular, intracellular, is that what you mean?
Say it again.
Extracellular, like, is that what you mean? ECA?
Yes, that's what I mean. Yeah, perfect. So what component of it is extracellular?
What's in your plasma?
Good. So extracellular is comprised of intravascular and
interstitial.
Yes, and
Your CSF, would that be?
yes, yeah. So it's called transcellular, and it comprises of the fluid that's in the GIT, in the CSF. Like bile is another like source of
synovium fluid, like
synovial fluid. Yeah, exactly. So all those little pockets of fluid that don't quite fit in any other category. So it makes up less than 1% of the total body water. It's not very significant. Wait, I think it's 2%. 2%. Sorry. Very like pretty insignificant, but it is potentially a source of fluid that might contribute to shifts, particularly GRT, that can change quite rapidly. So very good. So extracellular has 3 parts to it. Transcellular we won't talk too much about, but we will talk a lot about interstitial, and we will talk a lot about intravascular because they're the big shifts that we see in fluid balance. What's the extracellular and
Extracellular.
first? Thank you. Good. So what component of body fluid is intracellular?
about
2/3.
Yeah, good. Yeah. So 66, 70 sort of percent of body fluid is inside the cells. So then if we know where the fluid's living, actually I should say how much is in the intravascular compartment.
It's 20% of your total body.
it's about 5 or 8%, I think, intravascular.
Intravascular is actually only 8%.
8%.
Yeah, so that 20% of total body actually makes up interstitial and intravascular. So it's the fluid balance that you're playing with when you're calculating your fluid deficit.
Sure.
So the actual intravascular component isn't very high, it's only about 8%. So then if we've got 60 to 70% in our cells of the total body fluid, not total body weight, I'm saying, so of the total body fluid. And then we've got another 30% sitting outside of that, and only 8% of it's intravascular, and only 1% of that, 2% of it is transcellular, the gallbladder and stuff like that. The interstitial fluid makes up the main component of fluid that we can then influence with fluid, right? When we're giving fluid therapy. That makes sense. Has everyone got like pictures of compartments in their head? Yeah, sort of.
That makes sense.
Okay. So if we say that the main compartments that we can influence are interstitial and intravascular, what is it that dictates fluid movement from the intravascular space into the interstitial space or vice versa?
Osmotic and hydrostatic pressure.
Oh, such a smooth answer. Very good. So what laws do we use?
Starling, is it Starling?
Starling's law, yes, thank you. Excellent. That dictate hydrostatic pressure and osmotic pressure, on the influence that has on fluid movement. So if you've got increased hydrostatic pressure inside your capillaries, what's going to happen to your fluid shift? Where's it going to go?
Moves out.
Moves out. And then if you're very dehydrated, decreased intravascular fluid.
Fluid moves in.
Fluid moves in, exactly. As long as there's enough fluid, like there's going to be balance. If you're getting dehydrated and both your interstitial and your intravascular volume are depleted, you're going to be at equilibrium at lower volume in both, right? So hydrostatic pressure is actually the main influence of fluid movement. Osmotic pressure has a much lower impact on movement in the extracellular fluid space. So this is where there's a little bit of controversy. Has everybody heard of the endothelial glycocalyx?
Yes.
Does anyone
Yes.
want to tell us about it?
I don't understand it.
It's just like
A layer of, I think it's like, I don't really know what it's made up of.
you like
Things
a
yeah,
like
like a carbohydrate, I don't know. Lines the lining of your
Good.
like your endothelium, so of your vessels.
Yeah.
And so the idea being that it's a big driver of like how permeable your vessels are.
Yes.
It's important for coagulation because it's that inner surface that everything's
Yeah.
going to stick to. And when your patients that are critically unwell, it becomes leaky and can be quite badly damaged.
Yeah. Unwell, different medications can damage it as well. Different fluids, like even just crystalloids and colloids can damage it as well.
Yeah.
Or they can help it, depending on who you ask and where the controversy is on that given day. So essentially the glycocalyx has really influenced the way that we think about fluid shift, which is why I'm raising it now. So where we used to think hydrostatic and osmotic forces were the main forces between fluid shift, what the glycocalyx does is provides this lining on the inside of the endothelial walls, which actually almost removes the osmotic component to fluid shift. So it provides this kind of buffer where, like, so you get glycocalyx and then you've got this subglycocalyx kind of layer of fluid, which kind of buffers that osmotic movement and stops the fluid from then going into the extracellular space or interstitial space due to osmotic drag. Because obviously the outside the cells has like quite a lot of protein. It's tissue, right? It's going to have more protein than inside the cell. So if osmotic influence was like the main influence, we'd have fluid just continually leaking out into the interstitium, and then the lymphatics would have to clear that. So what this kind of knowledge about the glycocalyx tells us is that osmotic pressure doesn't have much to do with fluid shift until that glycocalyx gets damaged. So if you end up with hypoalbuminemia, that will damage the glycocalyx. If you end up with a medication which causes vasculitis or any cause of vasculitis, systemic inflammation, and certain fluids and things, you damage the endothelial glycocalyx, and then all of a sudden the osmotic forces cause more shift in fluid, so you get more extracapillary shift of fluid. So basically any animal that's critically unwell should be treated as having an unstable glycocalyx, and we should be more aware of how we're impacting osmotic pressure, because that's going to have more impact on fluid shift.
There's actually like critical care, the sicker the patient, the lower the fluid requirement. So there's actually a different, like, you know how we just say 2 point, like maintenance, but their maintenance rate is not the same as 2.5. It's a bit lower.
Yeah.
Because of, I think, this reason.
Yes, but I actually find calculating fluid rates very difficult, and I don't want to talk about it. Sorry.
There's so many opinions. Different people will say different things too.
So many opinions, and like a lot of the kind of automated calculators and stuff like that use a fluid rate that I'm actually like, that is way too low. But that's probably because I deal with patients that have increased fluid losses, urinary fluid losses, because they've got Cushing's or heart disease or like, you know, other causes of. So my idea of what a maintenance fluid is for my patients is quite different from the young healthy patients coming with a fractured leg, as an example. Anyway, I find that very confusing. So that's really all I wanted to make sure that we covered. Well, there's so much more interesting things to talk about. No, I'm not going to go into actual fluid therapy. The only thing I wanted to make sure everybody knew, what is a buffered fluid?
Like Hartman's?
Yeah, but what does it mean?
Means it's been buffered.
By what?
But like the pH is similar to the plasma?
Yes, good. So it is to like with a goal of influencing pH. So instead of having chloride as the anion, they use buffering anions. So lactate is the most common one, lactate ringers. So they
maintain they can buffer and maintain like
exactly
like
so they can
buffer changes.
Yes. So rather than actually influencing the pH of the fluid itself, it provides tools for the body to then buffer pH better. Sodium chloride is very acidic. It's like 5%. I mean, pH of 5. Opposed to, you know, our body's trying to maintain a pH of between. Ridiculous, tell me. 7.35 and 7.45 or something like that. So if we give NaCl, we're giving something really acidic, and the body uses up all its buffering anions trying to correct that deviation that we've caused. Whereas if we give a lactated ringer solution or a buffered solution, like Plasmolite's another example, we're providing it with the tools to then manage any pH change that we're causing. Makes sense? That was really hard for me. I don't know if I'd never ever really comprehended that. Anyway, we need to wrap up. That was really fun. Thank you.
Thank you.
Thank you.
Thanks, Anna.
See you,
Thanks,
everyone.
everyone.
Thank you.
Bye.
Bye.